All right, thank you all so much for joining us for this month's meeting of our remote monitoring working group. We've got a few updates that I wanted to go over with folks, some of which we've covered in previous meetings with some new updates. The big one being that there's been a new development in terms of the upcoming January 30th deadline that I wanted to make sure that everyone in the community is aware of, as well as some updates regarding the Rural Health Transformation Program and the funds that are being distributed through that. And then I wanted to review some of the pieces from the RFI from HHS about AI policy, as well as the HTI-5 proposed rule. And then, of course, any other items that we don't bring up during the meeting, and I'll also talk a little bit about tomorrow's webinar. So, last week there was a bill to fund a handful of government agencies through the rest of the fiscal year to the end of September of this year. Um, and this included both the HHS funding as well as a number of healthcare extenders, one of which was an extension of telehealth flexibilities through the end of 2027, um, a 5-year extension of the hospital at home program, as well as there was a new piece that was added. And interestingly, this was the only mention of artificial intelligence in the entire 1,000-page bill that directs HHS to conduct a study of wearables and other personal health devices, um, which I think, at least for purposes of this working group, would have been most relevant. Um, this, of course, after HHS's leadership's interest in promoting the use of wearables and other health tech devices. However, after the increased uproar over ICE that has since this weekend. Democrats have now said that they would not advance the House passed bill, which includes funding for the Department of Homeland Security. And this is coming from Schumer, who is saying, quote, Democrats will not provide the votes to proceed to the appropriations bill if the DHS funding bill is included. And of course, the bill that these health policies are in is also the same bill. This bill also includes DHS, DOD, transportation, housing and urban development, education, labor. And so it's a pretty big bill. And now with Democratic leadership saying that they will not advance the bill in its current form, there is an increased likelihood of there not being a deal by the end of this week. Of course, the January 30th date is this Friday. Um, and so if the Senate does not pass the bill as was passed by the House, or if the House does not pass a different bill as passed by the Senate, there will at the very least be a partial shutdown. Some government agencies have been funded through the full year, but HHS and a handful of others that were in this bill will go without funding and will enter a shutdown if this bill is not passed. Of course, part of this is that the House is out of session this week. And so, kind of similar to back in September, the House passed a bill, has left session, and is kind of giving the Senate the option to either pass the bill as is or risk entering a shutdown. Of course, this means that telehealth flexibilities are at stake again. And we've been wanting to make sure that members are aware of this, that there's an increased likelihood of there being at least a partial shutdown and an expiration of telehealth flexibilities. Um, and if there's anything that CTeL's can do in terms of helping plan for any sort of contingency planning, we're happy to set up some time to meet or help out with that. Any questions on this?
No, I had heard this morning about the DHS and holding that kind of in at bay because of that piece. And as soon as the riots happened, I kind of knew we had a problem. So I don't know if everybody else is feeling, I don't know how many people are on here, but I was just talking with legal about, our plan B. I mean, everything's in place like we did last time. But I guess my question would be, do you think there's going to be room for discussion immediately upon the return of the house? Is this going to be an option? And what is the vibe? I'm sure they're not going to roll back on the funding they're asking for, but I don't know if anybody else has heard anything.
I've
Yeah.
only heard people doing the same as the last shutdown
Yeah. Yeah.
activities, but not around just because this is so fresh.
Yeah, of course, at least in terms of what the president is saying, um, there there seems to be an interest in pushing forward with the bill as is. Um, and so there's likely not going to be any pressure from the White House to change the bill.
Mm,
Um, and of course, with the House being out of session, it very well may be the same thing that the House says, well, we passed the bill, we did our job, and we're not coming back until the Senate is ready to pass our bill, which is kind of what the message that Speaker Johnson was giving over the course of the previous shutdown. And so it will depend on whether Schumer and other Democrats continue to hold out over the course of the week. And if Senate Republicans can't find another 7 Democrats to join with them to vote for this. Um, but if that, but if the holdout does continue through the end of this week, there'll at least be a partial government shutdown. It won't be a full government shutdown. The continuing resolution that expires this Friday included full year funding for a handful of agencies. And Congress has been working over the past few weeks to fund a handful of other agencies. But with this bill being the last few agencies and also one of the biggest, if this goes down before the end, by the end of this week, then we will see another partial shutdown. And we, of course, will continue to um, keep you all updated as developments occur. Um, Neither outcome, either a shutdown or an extension, is guaranteed as of yet. Um, but given the developments and recent statements by Democratic leadership, um, the dynamics have changed in recent days.
that is really unfortunate.
Another update that I wanted to talk a little bit about is the Rural Health Transformation Program. Um, This was a $50 billion fund that was included in the One Big Beautiful Bill Act passed in July of last year. This $50 billion is to be allocated to states over 5 years, so $10 billion each year. And the way that the funding is being distributed to these states is that half of it is being distributed equally, and then the other half added on top of that is being allocated at the discretion of CMS based off of applications that states submitted saying that what they wanted to prioritize with the funding from this program. And so late December of last year, CMS announced the final award amounts um, that will be distributed to states. And since then, states have begun putting together the infrastructure for actually distributing these funds. At the moment, CTEL has been tracking kind of sort of the next steps from states in terms of how members, organizations, practices, developers, and other interested parties can actually start applying for this funding. Um, through the state governments because the state governments are the ones who will be administering these funds. At the moment, it seems that the state governments themselves have not actually received the actual money to distribute. CMS has just announced what the award amounts are. And so a handful of states have already started having listening sessions. Some states are calling special legislative sessions to include this in their state budgets. Some states are putting together advisory committees to oversee this funding distribution. And of course, over the coming months, there will be requests for proposals, funding opportunities, and other opportunities for members to engage with this funding as it's going out. And so we're currently working on building out a tracker for all the state programs and all the information that we can find for these states to help members if there's any interest in either applying for this funding or in any way getting involved with the distribution of these funds. Any questions on the Rural Health Transformation Program?
Lydia, thanks for the tracker. Do you have any sense of when you will be able to publish that?
We're currently working on it right now, and it should be online on through the CTeL member portal within the next day or two. It's currently in like
Great.
spreadsheet form, and so we're just working on getting it put into the website and brought online.
Great. Thank you.
And we'll send out a notification to everyone once it's available and ready on the website. I also wanted to highlight a response letter that CTEL is currently preparing on a request for information from HHS, um, see, looking for information that, quote, HHS can do to accelerate the adoption and use of AI as part of clinical care. Um, I wanted to just bring this up, of course, given that there's a lot of overlap between AI and remote monitoring, especially as the two technologies seek to integrate more and provide more insights for patients and clinicians. And so I wanted to highlight one of the questions that CTEL is working on a response for and see if anyone in this working group had some thoughts on some points that we might want to highlight in our response. And this is question 9 from the RFI, which states, what challenges within healthcare do patients and caregivers wish to see addressed by the adoption and use of AI in clinical care? And equally, what concerns do patients and caregivers have related to the adoption and use of AI in clinical care?
So I think we largely discussed this, but it was a lot around the privacy. And I think from a clinician standpoint is the models used and the bias versus hallucinations. Um, how um, how are we going to gatekeep for that? I think is a big concern.
There's that. And then there's also, in conjunction, the new certification regulation, HIT 5, which is defining that a request from an AI, if institutions do not reply to that and engage with it, that will be considered information blocking. So I think this in this time when we're trying to facilitate innovation and also manage expectations and privacy. Um, I think that need to be mindful around putting institutions like hospitals in a position of a no-win, where they're not able to comply with either conflicting regulations, and have some concerns around patient and provider privacy.
Has there been any indication from the malpractice industry on how that might feel, particularly about subrogation if they have to uh, against an AI device that maybe committed some sort of sin that that excludes coverage if it happens, kind of thing. Not necessarily my area, but in the privacy work that I do all the time, they keep showing up as big players by their ability to carefully exclude something that AI can be shown to have somehow touched, and thereby prevents from paying a claim. Anybody got a comment on that?
Agree, despite requirements, and states are not allowed to create laws around this now. So it's becoming increasingly difficult to comply.
All good points, and I think it definitely highlights the fact that there's a lot of shared concerns among patients, caregivers, and clinicians, um, and that there's kind of more of a common interest in more assurances, at least from a regulatory side, to protect patient privacy. So we can definitely make sure to incorporate those points into our response letter as well. As Michelle mentioned, I did also want to highlight the HTI-5 proposed rule, which is a significant overhaul of some of HHS's health IT regulations. Um, the agency is proposing to remove 34 certification criteria and revise another 7, as well as revising a handful of information blocking provisions, as Michelle mentioned, having to do with agentic AI agents and robotic process automation. And specifically, HHS is seeking to revise its definitions of the terms access and use when it comes to information blocking, to explicitly include the access and use of health information by agentic AI tools, as well as proposing new guidance to say that an actor's practice that interferes with, prevents, or materially discourages the access, exchange, or use of health information by automation technologies could implicate the information blocking regulations. And HHS is formally withdrawing any of the unfinalized proposals from the HTI-2 rule, um, that was recently, not recently, but that was previously proposed as well. And if
Which
you're interested,
and
Mhm.
sorry, Lydia.
I was just wanting to mention that CTEL does have resources to help you understand kind of the basics around information blocking and the main points that you need to know. We have both a fact sheet as well as a webinar we did um, with an information blocking legal expert that goes over some of the main considerations in recent regulatory updates as well.
So HIMSS is also doing some significant work under the public comment for this change. The discussion has been generally okay in terms of the changes to certification. There were a lot of vendors in that forum, but not including requirements for certain elements in the system that we know the vendors are going to continue to support. Was not, was generally in the HIMSS forum thought to be fine if they remove that requirement. One that was discussed at length was around some of the gender identification requirements, and that those have all been removed. And so the vendor community seemed to indicate that they were going to continue to support that. But in that forum, there was discussion about whether they should include it in the public response, in the public comment response, at least to show that this is an important clinical decision, a point, or a need for this information around gender identity and gender um, uh, pronouns, et cetera. There's some other elements, and maybe Lydia, you have that handy, I'm not sure. But I would submit it to CTeL to maybe do the same so that at least it's on record. I think everyone felt pretty confident that the administration would not change its position. However, doesn't mean if, we obviously, from a clinical perspective, this is important information to be able to treat a patient appropriately and with dignity.
For sure, and I imagine this will likely come up when the administration starts looking towards updating its US CDI standards as well.
Yes, and we understand this departments have to comply with the executive order, but it doesn't mean that departments and organizations like CTeL, which were, representing a lot of folks that are in healthcare space, that this is, it's important that we point out this is not frivolous information. That's important that we have this information to appropriately treat patients.
100%.
I just have one thing more. I'm spending an awful lot of research time and preparing to invest in more about the admissibility of AI tainted evidence, and it being in a matter of disputes. We're trying to make video evidence, for example, dispositive on presentation in the practice of pretrial motions, and it's a whole practice area, and it's really flummoxed by the introduction of AI, and especially defense makes motions that that by the virtue of AI, even barely mentioned, requires that tens of thousands of dollars and months of study must be applied before it can even be considered for admissibility, let alone being admissed. It's a kind of a, oh, a pocket veto kind of thing that can be tossed out and vitiate something that's been heavily invested in. And I don't know. I'd like to see at least some of the early stages of the proposed rule, with some anticipation that this rule will be cited in disputes downstream. That's all.
Can I understand the situation there? Maybe ask us further questions. So can you give me a scenario? So is the defense putting information forward that includes AI generated information, and therefore it's just sort of blanketly discarded? Is that what you're referencing?
Yes.
Interesting. Thank you. That almost seems counterintuitive to what the administration is trying to accomplish with AI, which is sort of to really take the guardrails off.
Well, um, my area is regulatory compliance and having to prove it when it's the alleged compliance is challenged as insufficient or improper. And so my evidence of compliance is presented, and the evidentiary quality has to be anticipated in advance because it's expensive to get the evidence. And I got to make sure that the evidence is versatile. We have a patent in that area, uh, which hopefully provides us just with some protection. But I'm using AI to try to examine the horizon of this stuff. And uh, it does not show me a lot of confidence for my own processes. So uh, I might be looking to CTEL for help to see how we could make the evidentiary quality of regulatory compliance more impregnable if possible.
It looks like Joe is asking what kinds of cases. He doesn't have audio, so I'm just reading his question here.
Sure. The case is has proper consent for the use of a person's biometrics been obtained for each instance of use, such as instance A, when the consent was presented to a state for a high stakes issuance of a license. And we serve the teleradiology industry, for example, all the big players. They're worried about this. Of course, I don't want to go into the diagnostic use of it, but the idea is of consent. What is proper consent? And we learned that there are multiple simultaneous enforcement jurisdictions, all applicable, and defining this consent differently. And that, according to some studies, 40% of the definitions are indistinct and non-specific due to pending litigation or legislation. And nevertheless, proper consent must be given right now. And months later, when they have decided on one, then retroactively it's applied, and improper consent is alleged. And there are bad downstream things such as shakedown settlements and awful things like that that occur. So we're trying to preclude stuff like that by having bulletproof, frankly, dispositive evidence that can be provided pre-trial to get our clients severed or used or have a dismissal or summary judgment issued. That's what we're going for.
I have a question.
Mhm.
I don't think I'm smart enough. So that's where my question is coming from. So when we have a standard telehealth virtual care consent and we have a standard of care, so when people come in, that is all a part of that. So I think what you're suggesting is you're saying that there are now additional types of consent for virtual care.
What's that?
Sorry, this is my boss calling.
Okay. I can't top that one. Oh, uh, I'm not an expert in the area. I've got a narrow view, but I know that consent is for the International Association of Privacy Professionals, 85,000 members strong. Consent is a real hot topic, and the fact that enforcement jurisdictions can't make up their minds what shall constitute it is a huge variable area. And the fact that they have codified fines in the order of 4% of an entity's total global annual turn makes it high stakes that it makes the whole thing ripe for extortion. So we're trying to duck, bob and weave, whatever it is, trying to find a way to make our clients immune to these threats. And might be approaching CTEL in some formal way to get some help with it.
For sure. And of course, we'd be happy to help with any initiative you're interested in taking. Um, I can follow up with you after this call if you'd like to set up some time to meet.
It's funded help.
And so that's all the main content to cover for today. But are there um, any other topics or questions in this space that we didn't address that we'd like to talk about? If not, then tomorrow we are hosting a webinar on our recent 50-state survey on audio only and asynchronous care. Um, I can put the registration link in the chat if you're interested in joining. Um, there you go. Um, and this is tomorrow, the 27th at 2 o'clock p.m. Eastern. And with that, that's all that we have for today's working group. Thank you so much for joining, and I hope you have a great rest of your day and stay warm.
Thanks again. Bye.